Welcome back to the Emergency Medical Channel. I'm Divya Rajan, a final year medical student, and this is Neha and Gayatri, who are also final year medical students. Here we have Baiju, who has volunteered to be our patient today. He has been admitted with breathlessness from the past 2 hours.
So can we start? Can I give the
Yes.
history now? So we have a patient who is 35-year-old male admitted with acute onset of breathlessness since last 2 hours. He had past history of moderate mitral regurgitation, and his ejection fraction was previously 40%. Now on clinical examination, he is tachypneic. So he is tachypneic, and he had previously MR, cardiac failure. Now he is admitted with acute onset of breathlessness. So you can start managing the case.
Okay, so first we have to connect the patient to the monitor.
Connect to the monitor. Everything is connected. I will tell the vitals. Anything else to be done?
And put him in the propped up
So
position.
you put the patient in propped up position.
As he is in breathlessness.
Okay. So we put the patient in propped up position. I will tell the vitals now. Okay. Whatever is shown in the monitor, his respiratory rate is 30 per minute. Saturation on room air without connecting the oxygen, it is 75%. And pulse rate is 125. It is regular. You can see in the monitor. And it is low volume pulse. BP is 110 by 70 millimeter of mercury. His JVP is elevated. Okay. So you can manage the case now. Whatever you want, you can tell the technician, she will do.
Okay, so first we'll do an immediate 10-second evaluation.
Okay.
Find out he's conscious, cooperative, and
He is
well
fully
oriented.
conscious. His GCS is normal. The only thing is he is tachypneic.
Okay, how is the airway?
Airway is good. Bilateral crepitations are there.
Okay.
On auscultation, bilateral crepitations are there.
And is there any secretions or frothing?
A lot of secretions. Frothy, he vomited last 1 hour.
Okay.
Frothy secretions were vomited.
So we'll do the chin lift and head tilt maneuver.
Okay.
And keep him in the left lateral recumbent position.
Okay.
And suction all the secretions
Okay,
first
everything
to
is
clear
done,
the
and
air.
after that he was shifted to this hospital. Now also he is having breathlessness.
Okay, so now is the patient on room air?
On room air, we have not started anything.
Okay, so first we have to start oxygen therapy immediately.
So please start oxygen.
Apply the Hudson mark. Start 6 liters of
So
oxygen.
you start 6 liters of oxygen.
Oxygen was connected,
Oxygen
6 liters.
started.
Okay.
And he is in proper position. He is breathing. Now we'll see the saturation.
Yes.
So there is no improvement in saturation after starting the oxygen.
Okay. Then immediately we can check the auscultatory findings.
Auscultation findings are similar. It is bilateral extensive crepitations are there.
Okay. So then we can start on BiPAP ventilation.
So you tell us.
IPAP is to EPAP, 12:6 ratio. That is the inspiration and the expiration ratio should be 12:6.
So remove this oxygen mask, connect to oxygen, BiPAP should be started. So she will start that.
Okay.
Anything else to be done?
After connecting.
Monitor is connected, BiPAP is started,
BiPAP
12:6 is started.
Okay, after doing that, we have to assess the respiratory system if there's adequate chest rise.
Okay, chest rise is adequate.
And bilaterally symmetrical.
Bilateral is symmetrical.
And if no distended veins
There
or
is no, only JVP is elevated.
only JVP is elevated.
Because he had mitral regurgitation in the past. Now we assume that it is cardiac failure.
Since he's having now tachycardia and hypotension, I would like to secure 2 large IV bore
put
cannulas.
Two large bore IV cannulas, 18 gauge.
18 gauge
You can
cannulas.
start. So she'll start IV. He'll start putting IV cannulas.
IV
So-
cannulas secure.
Secured.
Okay.
Anything else to be done?
Now, how if the BP has not improved?
BP is same, but saturation after starting the BiPAP has improved.
Okay, then we'll start noradrenaline.
Noradrenaline.
Because the BP has not yet improved,
Okay.
we start
So
noradrenaline.
we have to start noradrenaline as an infusion.
Noradrenaline started.
2 to 5
Okay,
microgram per
started.
kg.
It is started. We have to reassess after some times.
Okay.
BP was low, and we have started noradrenaline.
Okay. Then now after noradrenaline, for making sure the cardiac activity is efficient, we can start dobutamine.
Okay. So start dobutamine also infusion along with noradrenaline.
Dobutamine around 2 to 15 microgram per
Okay. So we
kg.
start 2 microgram, then we'll wait. Okay.
Started dobutamine.
Okay. So we have started noradrenaline, and you have added
Dobutamine.
dobutamine. Okay. We'll discuss afterwards why these things are started.
Okay, and then now we can start Lasix like furosemide
So you
because there's
start
fluid over there.
furosemide infusion.
40
You
mg.
start. You want to give a bolus dose or infusion?
Infusion dose.
Infusion. So you start infusion 10 units per hour. You can start.
Furosemide
10 mg per hour. You can
10
start.
mg per hour started.
Started. So we have started infusion of furosemide because of low BP. It is
Low
given as
BP.
infusion.
Now the heart rate and the BP should have been stabilized.
Heart rate is same, but saturation is improved. It is
Saturation.
improved to normal after
And the
starting the
BP?
BiPAP. BP is also improved after starting your noradrenaline and
Okay.
dopamine. It is 120/80.
Okay. Now I'll re-examine
Okay,
the
you
patient.
examine the patient. So when you are examining, you are hearing that there are bilateral crepitations. Extensive crepitations are there, but it has come down from previous examination. What I examined, it has come down, and you are examining the heart now. There is a pansystolic murmur there. That's all.
Yes.
Pansystolic murmur is there.
So the auscultatory findings are pansystolic murmur and soft S1.
Oh.
So it is directing towards a mitral
So
regurgitation.
he is already diagnosed as mitral
Past.
regurgitation in the past, and you get a pansystolic murmur with soft S1, and patient is managed well, and patient has improved now.
Okay.
Now, what else you can do for this patient? He is in emergency room. We have managed the case with minimal things, and patient has improved.
Okay.
Cardiac failure has improved. But what investigation? Whichever investigation you want, we'll do it.
Okay. First, we can send for an echo.
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 Echo is already done in the past,
Okay.
and it is not going to give
Then
more
we can
information.
do an X-ray and ECG.
So X-ray is taken. X-ray shows bilateral extensive shadows that shows pulmonary edema is there.
Okay. And ECG findings?
ECG was showing only tachycardia. There is no other change.
Okay. Why I would like to repeat the echo to check the ejection fraction whether it has
Ejection
improved
fraction
or not.
was previously it was 40%.
Okay.
Now because of tachycardia, we are not able to assess the ejection fraction.
Okay.
It takes some more time to assess the ejection fraction. Once the patient settles, we can do
Okay.
one more echo.
Okay. Then we can rule out if he has any infections.
Okay, he had fever 1 week back. He had
Okay.
cough. He's a smoker. So
Okay.
possibly there is some
infected
infection, respiratory infections are there. So for that we have done the counts. Counts are elevated.
Okay.
Procalcitone is elevated. So it probably looks like a bacterial lung
Okay.
infection. What antibiotic you want to start, you can start.
Antibiotic, if it's a bag, we can start third generation cephalosporin.
Which one you want to start? Third generation cephalosporin.
Ceftriaxone.
Ceftriaxone. So we start ceftriaxone. We'll discuss afterwards what all things can be done. Okay.
Then if he's having any anemia, any renal function problem.
Anemia is not there. Renal functions are normal.
Liver
Creatinine is
function.
Liver function is also normal.
And thyroid?
Thyroid is normal.
Okay.
Okay. So these basic investigations are done. Now this patient is, you know that there is cardiac failure.
Okay.
How do you manage cardiac failure when you discharge from this emergency room? You have to shift this patient to ward. What are the drugs we can start for him?
We'll start him on medications, triple therapy. We'll start first ACE inhibitors we can give,
Okay.
such as captopril,
Okay.
Around 6.25 mg.
Okay, so you can initiate enalapril, captopril, or ARB. Anything can be done.
Okay.
What is the use of these drugs?
It will prevent the remodeling of the
Ventricular
left
remodeling.
ventricular.
Ventricular remodeling can be prevented. Okay, so AC inhibitors or ARB can be started. What is the second drug?
We can give beta blockers.
Beta blockers.
Like metoprolol.
Metoprolol. What is the action of beta
25.
blocker?
It will reduce the heart rate.
It reduces the heart rate so that the heart
Effective
can effectively
oxygenation.
pump more blood. Okay, so reduce the heart rate. Third drug is
We can give diuretics like spironolactone.
Okay, spironolactone with Lasix. So
Lasix.
you have already started infusion of Lasix, and we have to add spironolactone. So these are the basic drugs you start in cardiac failure, and you have to see other things, and we can start accordingly. Okay, but
And
yes,
further for like if he's having like pain, we can also start him on sublingual nitroglycerin.
sorbitrate, that also can be given. But you have started noradrenaline. We go back to the what all drugs you have started.
Okay.
You have started noradrenaline and dobutamine. What is the action of noradrenaline?
Noradrenaline,
It increases the BP.
Yes.
When he was admitted, his BP was low. Okay, if the BP is low, the perfusion all over the body is going to come down. So any hypotension, noradrenaline will be a good choice in all the hypotensions. So we have started noradrenaline,
Noradrenaline
but you
increase.
added dobutamine also. Why you added dobutamine?
Dobutamine for the cardiac activity for effective
So
contractions.
it improves the contraction of heart. It improves the pumping of the heart.
Yes.
Okay, but why don't you start dobutamine first? That will not that.
Noradrenaline because it will have an immediate effect.
So immediate effect, and dobutamine there is another action. It dilates the blood vessels. So when the patient is in hypotension, if you start dobutamine initially, BP will further fall down. BP may drop down. So we don't want that. We want BP has to increase, then perfusion has to increase, then we start dobutamine. Okay, that's why we select this drug as a second line drug. Okay. So this patient has improved. Now you want to go back, revisit and examine the patient. I will tell the finding.
Okay.
You examine the heart, cardiac. So you auscultate in the mitral area. I will tell the finding. Auscultate in the mitral area. Here. Okay. So what finding you are getting? I will tell you. There is soft S1. There is a pan-systolic murmur, and there is S3.
There is S3.
So there is a soft S1. There is a pan-systolic murmur. There is S3. So what does it mean? What do you mean by soft S1?
A soft S1 is
S1 is produced because of what?
the closure of the
mitral valve. So mitral regurgitation means mitral valve is not closing properly. So it tried to close, but it is not closing properly. So what will happen to S1? So
S1
there is
will
no
be
S1 or soft S1. Then after that, after closing, blood ejects. Okay, through that leaky valve, blood goes up. Okay. So what happens? There is a murmur. Okay. Not up, it goes
towards the
towards left atrium. So it doesn't close, and it opens like this, and blood
goes back
ejects or gushes through that leaky valve. Okay, so you get a pan-systolic murmur. So valve is not closed, that produces a soft S1. Then blood go through that leaky valve, that produces a pan-systolic murmur. Then I told one more thing. S3. What is S3?
S3 is like the aortic, actually like after the diastole, the further like
So
the
S1,
rest of the
S2,
blood will get.
Then there is another heart sound.
Atrial
S3.
kick it is also.
Atrial kick is different, but this is classically seen in cardiac failure.
Correct.
Okay, I am not telling the mechanism of S3. S3, if you are hearing an S3 in any patient, you should suspect cardiac failure. Okay, so what you are hearing is a soft S1, pan-systolic murmur, S3 is there. So he is in cardiac failure. Now discuss about mitral regurgitation. What is mitral regurgitation?
Mitral regurgitation is due to the valve, either it is obstructed.
Valve is leaky, that's all. Valve is leaky. Okay, so when the diastole pushes blood during systole, normally blood will go to the aorta. But here it is leaky, so it go to the left atrium. Okay, so what happens to the left ventricle? What happens to the left atrium? Left ventricle?
The pressure in the left atrium will
increase. It is
increase.
not pressure, it is volume. That is the difference. Okay. So large amount of blood is coming to left ventricle. So slowly left ventricle enlarges.
Hypertrophy.
Okay. Dilates. It is not hypertrophy. The word is dilates. Hypertrophy is a pressure overload condition. This is dilates. So now I am asking a question. Left ventricle dilates. So what happens to the apical impulse in mitral regurgitation?
It will shift.
It will shift out and down.
No.
Okay. It will shift out and down. Okay. So if you are getting a apical impulse which is shifted out and down, what is your diagnosis in mitral regurgitation? It is simply tells left ventricular dilatation. Okay. Now, if you see that lot of blood is going to the left atrium, what will happen to the left atrium? That also dilates.
Volume.
Okay. So volume overload can happen there also. Now, this volume from the left ventricle go to left atrium. So some blood is coming from the pulmonary circulation to left atrium. What will happen to that circulation?
That will also further increase the.
So that cannot enter there. The blood from the lungs will not be able to enter to your left atrium. Okay. So patient develops pulmonary edema. So what is the reason for pulmonary edema here?
Because of
it's the volume overload in the left ventricle, volume overload in the left atrium. This volume overload will be transmitting to the pulmonary circulation. That's why he is having breathlessness. So what is the treatment you are giving now to remove that volume?
Diuretic.
You give diuretic. Okay. But you have started BiPAP. Why it is like that?
To improve the breathlessness.
So it gives some pressure. You are putting pressure. 12 is to 6. Okay, 12 to inspiration, 6 for expiration. Okay, so in that pressure, air is going inside your alveoli. So what will happen to the alveoli, which contains water? When you put pressure, alveoli expands. The water in the alveoli will go out. Okay, so alveoli will be free of water. Okay, so what happens to him? Now you can see here he has improved. Why he has improved? It is not because of Lasix. It is improved because of
BiPAP.
BiPAP. Okay, BiPAP gives immediate effect. Okay, but that water
Positive
is there
pressure.
inside his body. To remove that, you have to put Lasix.
Lasix.
That's why you have started Lasix. Okay, now you have started other drugs like dobutamine.
Dobutamine.
What is the action of dobutamine? It improves the contraction of the
Contractions.
ventricle. Okay, so it improves the contraction of ventricle. So whatever blood is there in the ventricle may be contracted and pushed out. Okay, but in mitral regurgitation that may not happen. Unlike like cardiac failure due to myocardial infarction and all, here the valve itself is leaky. So even if you start dobutamine, sometimes patient may not improve. Okay, that also you should keep in mind. Okay, now talk about mitral regurgitation. You are told that there is a leaky valve.
Yes.
Okay, so which all chambers are involved there?
Left ventricle
Left
and
ventricle
left
and left
atrium.
atrium. Okay, and like I told, the patient can have pulmonary edema also. Now, what clinical findings you get in? What are the causes of mitral regurgitation? You might have read. What are the causes of mitral regurgitation? Rheumatic. First, the most common
SLE
cause
and
is
rheumatic.
rheumatic. Most common cause is rheumatic heart disease in our country. Then
SLE.
SLE is another cause, but he is a male, no?
Okay.
He is a 35-year-old smoker. What else he can have? Myocardial infarction and papillary muscle dysfunction and leaky mitral valve. Okay, that is a second common cause. And suppose you have a very tall, thin individual with mitral regurgitation. Marfan's. Okay, mitral valve prolapse. That also can sometimes produce mitral regurgitation. Then, like you told, SLE can be there. Okay, infective endocarditis can be there. So many other reasons can be there. So these are the causes for mitral regurgitation. Now, you have a patient who is having mitral regurgitation. You assume that it is due to myocardial infarction. How do you know that it is severe? How do you know that severity? Now you are telling it is mitral regurgitation. You tell the cause may be due to myocardial infarction, previous myocardial infarction since he is a smoker. How do you know that it is severe?
Ejection fraction.
That only after ECMO. As an
breathlessness.
MBBS student, breathlessness. Okay. Pulmonary edema is one of the classical findings seen in severe mitral regurgitation. Then you have auscultation, you got a clue. S3. Murmur is
S3
seen in
and
all.
pansy. Okay,
S3 is the classical feature you get in severity. Whenever mitral regurgitation is mild, you don't get S3. Whenever cardiac failure is associated with mitral regurgitation, you get S3. So S3 and pulmonary edema indicates that patient is having a severe mitral regurgitation. And you already know that our previous echo shows on ejection fraction is only 40%, normal being 50%, this is low. Okay, so it is moderate to severe mitral regurgitation. Okay, now how do you what are the other clinical findings you can get in mitral regurgitation other than this pansystolic murmur?
It can be a soft S1.
Soft S1. I told why soft S1 valve is not closing properly. Then
and then
can you get a diastolic murmur in mitral regurgitation?
usually it will be seen in mitral stenosis.
Usually it is seen in mitral stenosis. But you just imagine lot of blood from the ventricle is going to the atrium. Okay, what will happen to that blood? It has to come back to the ventricle. During diastole, it has to come back to the ventricle. So the flow in that area is more. Okay, more blood during diastole is coming to ventricle. So the amount of flow is very high. That means you are likely to get a murmur there. You are going to get a mid-diastolic murmur. Okay, so severe mitral stenosis, you can also get a mid-diastolic murmur because of the flow. Okay, so that also can happen. Okay. Now, what other findings you can anticipate other than all these things? You can get bilateral crepitation, like this patient had bilateral crepitation. Then
you can get other like
pedal
acute onset
edema?
of breath, pedal edema.
So you can get pedal edema,
Because of the pulmonary
fluid overloaded condition. Then JVP?
elevated.
JVP is elevated because he is volume overloaded. Okay. Then how do you manage this case now?
After that, after giving the medications, then we have to advise him about exercise and diet. We'll give that we'll advise him for graded exercise.
Okay, you ask the patient to do graded exercise. Then
Yes. And
diet
then,
you told. What diet advice you want to give?
diet, because of we can give a low carbohydrate, low fat, high protein.
What is the need of all these things? It's not. We are not discussing about myocardial infarction. We are discussing about
Mitral.
MR. Okay. And volume overload. Myocardial infarction. What
Then
you
avoid
told?
the smoking.
He has to avoid
because he's
smoking. Okay. Then
Uh,
what? How much water he can take? How much salt he can take? These are the-
salt restricted diet.
Salt should be restricted. Water should be restricted. So you give 1 liter, 1.1 liter water, and salt should be restricted to 2 gram per day. Normally we take 6 grams salt in a day, but he has to take a low dose of salt, 2 grams. What is the importance of salt in diet?
Water retention.
It can retain more water. So you avoid excess water intake. You avoid salt so that his water retention will be less. Okay. What else you advise for him?
Then
Can you medically treat mitral regurgitation?
medically no.
Medically, no.
Surgically we have to
Surgically.
replace the valve.
So you have to replace the valve. That's all. Okay. Either surgically or percutaneously, you have to replace the valve. That's all. Okay. There is no medical treatment.
Further, we can give medications to prevent further effects like aspirin, clopidogrel.
Aspirin, clopidogrel, all can be given in myocardial infarction. What you told is correct. He is having suspected myocardial infarction. You can give aspirin, clopidogrel, statin, all these things. He has got some dental problem. Now he is going for dental extraction or dental cleaning, scaling. What advice you give for this patient?
It can prone to infective endocarditis.
Aspirin 5 days before.
Okay, you have to stop aspirin. Suppose he is taking aspirin at least 2 days, 48 hours prior to that, you have to stop aspirin. Then antibiotic prophylaxis should be given for what?
Infective endocarditis.
Infective endocarditis. So mitral regurgitation is a risk for infective endocarditis. So if he is going for dental extraction, dental scaling, we have to give antibiotic to prevent infective endocarditis in mitral regurgitation. What are the lesions in heart can produce infective endocarditis? Which are the lesions which can which has got high incidence of infective endocarditis? One is mitral regurgitation. Or tell me which are the lesions has got least occurrence of infective endocarditis in heart lesions? One is mitral stenosis, and the one is ASD. ASD and mitral stenosis. The incidence of infective endocarditis is very low. Okay. So you should know that also, because when to give infective prophylaxis and whom to give infective prophylaxis, that also you should know. Okay. Suppose he is having mitral valve prolapse. Okay. Should we give infective endocarditis? Mitral
Prophylaxis.
valve.
Should we give prophylaxis?
Infective endocarditis prophylaxis.
No, that is
not,
lesser.
It is
not a
not
risk
required in mitral valve prolapse. But if the patient does MVP with MR, then you have to give. Okay, only in MR you have to give. Okay. Now auscultate again and tell whether patient has improved or not. Because he is on BiPAP, can we put him on oxygen? Saturation has improved. Patient is comfortably sleeping. Can we give morphine for this patient?
He's not in pain.
Huh?
He's currently not in pain. So
He's not in pain, but morphine, advantage of morphine is whenever you are anxious, okay, a small dose of morphine, subcutaneous, 2 milligram, make the patient sleep, okay. Because in emergency room, most of these patients will be highly anxious, okay. So their tachycardia can happen, their condition can worsen. So even if you give small dose of morphine, there will not be any problem. Okay. Can you give salbutamol? You told salbutamol.
Salbutamol nebulization, if he's having underlying V's, we can give.
Okay.
But
So
BiPAP is the best.
Okay. So if you have nothing, you can give salbutamol. It dilates the at least the bronchus, but it can sometimes produce tachycardia and hypotension, and the condition can worsen. Okay. So how is the patient now?
Now still the murmur is still auscultated.
Okay.
So the only treatment for the murmur is surgery.
Changing of the valve. And can we remove the BiPAP now?
Now if the oxygen saturation, heart rate, everything is
Everything
okay,
is good. Patient is
we
settled. You have given Lasix and he has passed urine. Good amount of urine is passed. He is comfortable. And now we'll put the patient on oxygen mask. And 6 liter oxygen can be given. So if we are putting this mask, minimum 5 to 6 liter oxygen has to be started. Okay. Is comfortable?
Yeah.
Okay. So tell thanks to the patient.
Thank you.
Okay. Thank you.